Okay, let's jump into this deep dive. We've got your revision notes here on, well, a pretty specific condition.
Yes, African trypanosomiasis, sleeping sickness.
Exactly. And our mission today is to really unpack these notes for you. We want to pull out the absolute high-yield facts, the stuff you really need to know, make sure it sticks for revision.
Think of it as navigating the key points together. We'll look at what's crucial, why it matters. It's all based on the notes you've provided. Focus purely on African trypanosomiasis.
Perfect. So let's start right at the top. What exactly is African trypanosomiasis?
Okay, so fundamentally it's a parasitic infection caused by Trypanosoma parasites. And the key thing, how it gets transmitted, is through the bite of an infected tsetse fly.
The tsetse fly, okay.
Yeah, and if it's not treated, these parasites can cause serious damage, especially neurologically, severe symptoms, often fatal.
And just to be super clear, this is different from other trypanosome diseases, isn't it?
Absolutely crucial distinction. We are only talking about the African form today. There's American Trypanosomiasis, Chagas' disease, totally different parasite species, different insect vector, the reduvid bug, and importantly, different treatment.
Got it. African form only for this deep dive, and the notes mentioned there are two types within that.
That's right. You've got Trypanosoma brucei Gambiense, think West and Central Africa historically. And then Trypanosoma brucei Rhodesiense, which is more East and Southern Africa.
And both spread by the tsetse fly.
Both by the tsetse, yes, but a really high yield point for revision, the Rhodesiense form, it usually progresses much, much faster, a more acute illness.
Faster. Okay, noted. So moving from the what to the how, the etiology. We know parasites, we know flies.
Yeah.
Can we get a bit more specific?
Sure. The actual agents are those two subspecies, Trypanosoma brucei Gambiense and Trypanosoma brucei Rhodesiense.
Right.
And transmission, like we said, is via the bite of an infected tsetse fly, the Glossina species.
And how do the flies get infected in the first place?
They pick it up when they feed on the blood of an infected animal. It sets up that transmission cycle.
Makes sense.
And different tsetse species prefer different habitats, some like forests, others riverbanks or savannas. That affects where the risk is highest. The notes also say once a fly is infected, it stays infected for life.
Right, so it's a persistent vector. Okay, so who is most likely to be at risk? What are the risk factors we need to keep in mind?
Well, it really boils down to two main things: geography and exposure to the fly.
Okay.
So obviously living in or traveling to those specific endemic areas in sub-Saharan Africa is number one.
Naturally.
And then within those areas, it's about activities that put you in contact with tsetse flies. Think rural areas, outdoor work like farming, maybe certain kinds of tourism.
So specific activities increase risk.
Yes, and the notes specifically flag that tourists visiting East and Southeast Africa can potentially acquire it, something to bear in mind.
Definitely. So location and exposure. Now let's dive into what happens inside the body. The pathophysiology. How does this parasite actually cause sleeping sickness?
Yeah, this is quite something. So after the fly bites, the parasites get in and initially multiply in the blood and the lymphatic system.
Okay, stage one starting.
Sort of, yes. But the really critical step is their invasion of the central nervous system. They have to cross the blood-brain barrier.
And that's what causes the major neurological problems.
Exactly. That CNS invasion is the key to the severe symptoms.
And how do they manage to hang around for so long, evading the immune system?
This is, well, fascinating from a biological perspective. They have this incredible ability to change their surface coat. It's called antigenic-variation.
The Antigenicvariation.
Right. They're covered in these things called variant surface glycoproteins, or VSGs, and they can just switch which VSG they're displaying. It's like constantly changing disguise.
So the immune system can't lock on.
Pretty much. The immune system gears up to attack one disguise, but by the time it's ready, the parasite population has switched to showing a different one. This constant evasion leads to waves of parasites in the blood and fuels the chronic inflammation.
Wow, that's quite a mechanism. And that explains the disease progression, the two stages mentioned.
Precisely. You have stage one, the hemolymphatic stage parasites are circulating in the blood and lymph.
Before the brain invasion.
Correct. Then stage two is the meningoencephalitic stage. That's when they've breached the blood-brain barrier and are in the CNS.
And that's the really dangerous stage.
That's the stage that causes the severe neuroinflammation, and the notes are starkly clear on this. It is fatal if it goes untreated.
Fatal if untreated really underscores the seriousness. Okay, let's zoom out a bit. Epidemiology.
Right.
Where is this actually found globally and, say, in the UK?
Globally, it's geographically restricted to sub-Saharan Africa. You have the Gambiense areas and the Rhodesiense areas.
Right.
Now, there is some good news. Major public health campaigns over recent decades have massively reduced the number of cases. We're talking huge reductions.
That's all positive.
It is. But the notes rightly caution that the risk of epidemics hasn't gone away entirely, so ongoing surveillance and control are still vital.
And what about for someone revising in, say, the UK? What's the relevance there?
Yeah, good question. It's not endemic in the UK at all. Zero local transmission. Any cases you'd see are imported.
Imported how?
Almost always in travelers coming back from those endemic regions in Africa. So for revision in a UK context, it's rare, yes, but it's something you absolutely have to consider in a patient presenting with suggestive symptoms and that crucial travel history, especially perhaps travel to East or Southeast Africa for the Rhodesiense form.
Travel history. Okay, hammering that one home. So what are those suggestive symptoms? What does this actually look like clinically?
Okay, let's break it down by stage again. Stage 1, the early stage. This typically kicks in maybe around 3 weeks after the bite.
3 weeks. And what should you look out for?
Well, the tricky thing is, initially, symptoms can be quite vague, quite nonspecific. Things like just feeling generally unwell, malaise, fevers, but they might come and go intermittent, muscle aches, headache.
Sounds like it could be lots of things.
Exactly. But on examination, there are more specific signs. A key one is a painless sore or chancre right at the site of the tsetse fly bite. That's the Trypanosoma chancre. Very suggestive if you see it.
The chancre. Okay. What else?
Enlarged lymph nodes are common, particularly in the neck area. There's a classic sign called winter bottom sign, palpable posterior cervical nodes, also fever, maybe some swelling or edema, and weight loss.
Winter bottom sign. Got it. Non-specific symptoms plus travel plus maybe a chancre or a swollen neck glands. Definitely a challenge.
Yeah.
What happens when it moves to stage 2, the late stage?
This is the CNS involvement stage, and the onset here is often more gradual, more insidious, and this is why the name sleeping sickness really comes from.
Okay, so what are the symptoms now?
You get persistent headaches, profound daytime sleepiness, somnolence, but often, weirdly, paired with insomnia at night, so the whole sleep-wake cycle gets completely disrupted.
Not just sleepy then, but disordered sleep.
Exactly. And you also see significant behavioral changes, sometimes depression, neurological and psychiatric features combined.
And the signs in stage 2?
They reflect that brain inflammation. You see a gradual decline, poor appetite leading to anorexia, muscle problems, sometimes increased sensitivity to touch or pain, hyperesthesia. As it progresses, seizures can occur, and eventually, without treatment, coma.
Coma. Okay. Any other specific features across both stages we should highlight?
Well, reinforcing those classic ones, the Trypanosoma chancre early on, the pattern of intermittent fever, winter bottom sign, those enlarged posterior cervical nodes, and then in stage 2, really focusing on that cluster of CNS symptoms, the somnolence, the headaches, the mood, and behavioral changes, all stemming from the meningoencephalitis.
Remembering those classics sounds key. Given the vague start, what else could it be mistaken for? The differential diagnosis must be broad.
Oh, absolutely, especially if someone presents in or returns from an area where lots of infectious diseases are common. Malaria is top of the list.
Malaria, right.
And the notes make a really important point here. If someone is mistakenly given antimalarials, it might temporarily reduce the fever, which can mask the trypanosomiasis and delay the correct diagnosis. Plus, you can actually have both infections at the same time.
Co-infection.
Right.
It complicates things. What else is on the list?
Quite a few possibilities showing fever or swollen glands or neurological issues. The notes mention HIV infection, borreliosis, though the geographic overlap is different, brucellosis, leishmaniasis, toxoplasmosis, typhoid, and other enteric fevers.
Okay.
And you also have to think broader. Other causes of lymphadenopathy like TB or even cancers. And in late stage, other causes of acute confusion or meningitis. So yeah, a high index of suspicion linked to that travel history is essential.
Absolutely. So if you do suspect it, how do you confirm the diagnosis? What investigations are needed?
The definitive diagnosis relies on actually finding the parasite.
Finding the trypanosomes themselves.
Exactly. The notes say you need to look for them in blood, in fluid aspirated from lymph nodes, or in the cerebrospinal fluid, the CSF.
And how do you look for them?
Lab tests. Traditionally, microscopy is key, but serology antibody tests and molecular methods like PCR are also used.
What about just routine blood tests? FBC, ESR, anything useful there?
They aren't diagnostic on their own, but they can provide clues. You might see anemia, low platelets, thrombocytopenia. often high levels of gamma globulins in the blood and a raised ESR, maybe low albumin.
Okay.
But here's a really high-yield negative finding from the notes.
Yeah.
You typically do not see eosinophilia.
No eosinophilia. That's helpful to distinguish it from some other parasitic
And
infection.
that can be, yes. So routine bloods give hints, but you need to see the parasite. How's microscopy done effectively?
Yeah, how do you find them?
You can look at a wet smear of blood or make a Gambiense stain thick smear, searching for the characteristic shape and movement of the trypanosomes. But the parasite numbers in the blood can really fluctuate. They can be quite low sometimes. So concentration techniques are often needed.
Like what?
Things like spinning down the blood using hematocrit centrifugation or using mini-anion exchange columns. These methods concentrate the parasites from a larger blood volume, making them much easier to spot under the microscope.
Okay, concentration helps. What about antibody tests? Serology?
Yes, especially for screening large populations in endemic areas. The notes mention the CATT, the cardagglutination test for Trypanosomiasis. It's a standard field test, relatively quick and easy to perform. It helps identify people who might be infected and need further testing for confirmation.
TATT for field screening. Got it. Any other specific diagnostic tests?
Yes. You can aspirate fluid from an enlarged lymph node that can sometimes give a very quick microscopic diagnosis if parasites are present there.
Lymph node aspirate, okay.
And crucially, particularly if you suspect CNS involvement or always in the East African Rhodesiense form, which progresses rapidly, a lumbar puncture to get CSF is essential.
Lumbar puncture for CSF. What are you looking for in the CSF?
Primarily, you're looking for the trypanosomes themselves. But even if you don't see them directly, you look for signs of inflammation. An increased white blood cell count in the CSF, specifically lymphocytes and plasma cells, high levels of IgM antibody, and elevated total protein. These CSF findings are key indicators of stage 2 disease.
So parasites can be in blood, lymph, CSF, anywhere else.
The notes mention they can also be found in aspirates from that initial skin chancre, or sometimes even in bone marrow, though that's less common.
Okay. And the notes mentioned a kind of pragmatic approach sometimes used in rural Africa.
Yes. Reflecting the real-world challenges, sometimes a therapeutic diagnosis is used. Basically, you give a course of treatment and see if the patient's symptoms improve. If they do, it supports the diagnosis. It really highlights the difficulties when sophisticated lab tests aren't readily available.
Definitely brings home the resource limitations. Okay, so once you have the diagnosis, how is it treated? What's the management plan, especially thinking about a well-resourced setting?
Right. Treatment is complex and absolutely needs specialist input infectious diseases or tropical medicine experts. The single most important factor dictating the treatment is the stage of the disease.
Stage 1 versus stage 2 again. Different drugs.
Exactly. Completely different drugs. For early stage 1 infection, where the parasites are only in the blood and lymph system,
Before they cross into the brain.
correct. The drugs used are typically IV, pentamidine, or soramin. These drugs work well in the bloodstream, but crucially, they don't cross the blood-brain barrier effectively.
So useless if the CNS is involved.
Precisely.
Yeah.
That's why they are only for stage 1.
Okay. So what do you use for stage 2 when it's in the CNS?
For late stage 2 disease, you need drugs that can cross the blood-brain barrier to kill the parasites in the brain. Historically, the mainstays were melarsoprol, which is an arsenic-based drug, quite toxic.
Arsenic. Wow.
Yes, it has significant side effects, including a reactive encephalopathy that can be fatal itself. Or another option was eflornithine, which requires intensive IV administration. The notes clearly imply these older drugs have major drawbacks.
Yeah, sounds like it. Are there better, newer options available now?
Thankfully, yes. Progress has been made. The notes mention AT, that's nifurtimox eflornithine combination therapy. It's generally safer and easier to administer than the older regimens for Gambiense sleeping sickness, and it shows good efficacy.
EDACT. Okay, that's promising.
It is.
Hmm.
Drug resistance is always a background worry, but the notes mention that new drugs specifically for CNS trypanosomiasis are in development, which is also good news.
That's great. Beyond the specific antiparasitic drugs, what about supportive care? Acute management.
Yeah, that's vital too. You need to manage the acute symptoms, monitor the patient's neurological condition very closely, especially during treatment.
Why, especially during treatment?
Because of the potential drug toxicity like that melarsoprol and encephalopathy, and also because killing off lots of parasites quickly can sometimes trigger inflammatory reactions. In severe stage 2 cases, particularly if the patient is comatose, maintaining their airway to prevent aspiration is critical. Intensive care support might be needed. And because the drugs can affect various organs, you have to monitor blood counts, kidney function, and liver function regularly throughout treatment.
Sounds intensive. What about after treatment, especially for stage 2? Is that the end of it?
Not quite. Follow-up is absolutely essential after treatment for stage 2 disease.
What does that involve?
It involves periodic lumbar punctures, checking the CSF over time, sometimes for up to 2 years.
Checking for what?
Checking for any signs of relapse. Looking at the white cell count and protein levels in the CSF again, ensuring they normalize and stay normal. The notes explicitly state that relapse is possible.
And if relapse occurs?
Then you need to retreat, usually with a different appropriate drug regimen, again guided by specialists.
Periodic LPs for years
Mm-hmm.
really underlines the severity of CNS involvement. Okay, putting it all together, what's the likely outcome, the prognosis?
It really depends. Heavily influenced by how early it's caught and treated, and also by which species is involved. Remember, Rhodesiense is generally faster and more severe.
But the key takeaway is?
The absolute key point from the notes, the one to really remember. African trypanosomiasis is fatal if left untreated, especially once it reaches the CNS. Fatal.
Okay, but what if you do catch it early and treat it properly?
Then the prognosis improves dramatically, very much so. With timely and appropriate treatment, the notes indicate a high cure rate. Even for late-stage disease, using the right drugs leads to good outcomes in most cases.
So treatment works well if given correctly?
Yes, it resolves the symptoms and clears the parasites. High cure rates are achievable.
That's good to hear. One more thing on prognosis. If you're cured, are you then immune? Could you get it again?
Ah, important point. Unfortunately, no, the notes are very clear. Having had sleeping sickness does not give you protective immunity.
No immunity, so you could get reinfected.
Yes, absolutely. If you go back to an endemic area and get bitten by another infected tsetse fly, you can get the disease again.
That really feeds into prevention then. If there's no vaccine and no immunity after infection, how do we prevent it?
Well, large-scale prevention efforts focus on controlling the tsetse fly population and on case finding and treatment in endemic areas. Reducing the number of infected people reduces the reservoir for the flies.
Treating asymptomatic carriers, too.
Yes, finding and treating asymptomatic Gambiense carriers is part of the strategy to break the transmission cycle. But for the individual, since there's no vaccine...
It's all about avoiding the bite.
Exactly. Personal protective measures are key. Wearing protective clothing, long sleeves, trousers, neutral colors, as tsetse flies are attracted to bright or dark colors. Using bed nets in sleeping areas.
What about insect repellent?
This is an interesting detail from the notes and worth remembering. Standard insect repellents like DET are generally less effective against tsetse flies than they are against mosquitoes.
Less effective. Okay, that's a really practical tip. Finally, let's quickly cover the potential downsides if things don't go well, the complications.
As you'd expect from what we've discussed, the complications, especially with delayed or no treatment, are severe.
Such as?
Major risk of significant permanent neurological damage. This can lead to long-term problems with thinking, memory, coordination, cognitive, and motor impairments.
Literally.
Untreated, it progresses. Multi-organ failure can occur, leading inevitably to death.
And specifically related to the brain inflammation.
Yes, the meningoencephalitis itself can cause seizures, worsening stupor, and that classic coma associated with sleeping sickness.
Any other complications mentioned?
Anemia, chronic fatigue, and a wasting syndrome can occur. And as we touched on earlier, don't forget the potential complications from the treatment itself. Those drugs, especially the older ones like millarciprol, can cause serious adverse reactions.
Right, so disease complications and treatment complications. It really drives home the importance of getting the diagnosis right, staging it correctly, and initiating the appropriate treatment promptly.
Absolutely. It's a complex disease requiring careful management from start to finish.
Okay, so we've done a real deep dive there through your revision notes on African trypanosomiasis. We've covered the parasite, the fly, the 2 stages, the clinical features like the chancre and winterbottom sign.
The diagnostic methods focusing on finding the parasite in blood or CSF. The stage-specific treatments needing drugs that cross the blood-brain barrier for stage 2.
And the prognosis, prevention, and those serious complications. Hopefully running through it like this has helped cement those high-yield points for your revision.
We certainly hope so. Remembering the key distinctions and the progression is vital.
And maybe a final thought to take away as you revise. Just picture the difference between diagnosing and managing this disease in a specialist hospital versus a remote clinic with limited resources. Think about how the differentials might shift, how investigations differ, the treatment challenges. It adds a real-world perspective to the global health challenge these neglected tropical diseases represent.
That's a very important point to consider. The context matters hugely.
Absolutely. Now, if you were revising for exams like the MSRA, or just want to explore more medical topics, remember you can find a lot more resources, revision materials, and deep dives like this one over at pastmsra.com.
And also check out freemsr.com for additional helpful content.
Definitely worth exploring both sites. Thanks so much for joining us on this deep dive into African trypanosomiasis.
Yes, thank you. Until next time.